You want to let us know when we can go live?
Yeah, just a moment. Thank you.
Okay.
All right, take it away. Thank you.
All right. Good evening, everybody, and welcome to part 3 of our SCAI Interactive CME mini series, focusing on drug-coated balloons. Today's program is going to be with a world-class faculty, specifically focusing on guidance on imaging, lesion preparation, and deployment of DCBs in the coronary circulation. Obviously, tonight's program is action-packed, and I'm delighted to be joined by my good friend and colleague Ziad Ali. We will be moderating, and we have a really fun case-based format that's going to start with a case from Brian Bergmark from Boston, looking at single layer ISR, and then we'll move down the coast to Dawn Abbott and at Brown, and she's going to show some double layer ISR. And then we're going to look at other mechanisms of stent failure that we might use with DCBs, looking at underinflation or non-calcium management. And Emily Larnard is going to show us a case of that. And then we'll get an international perspective on ISR with Dr. Yuji Akari. And we're hoping that Margaret McIntyre, my partner from Columbia, will be able to join us if she's able to break free from the cath lab. So a couple of important things. Our disclosures are noted. This program is sponsored by an unrestricted educational grant from Boston Scientific. And we will be providing one Category 1 credit for MOC and CME as needed. And at the end of the program, you'll be sent a evaluation certificate, which will then allow you to get your CME credits. You can also find this in the My Courses tab on the SCAI Online Learning Center. And yeah, you'll have to sign in with your own account in order to get the credit. So with that, I will hand off to Z, and we'll get started with introducing our first talk. Z, you're muted.
Oh, thanks. Yeah.
Sorry.
So I'm glad to be introducing Brian Bergmark, who's going to be talking to us about single layer ISR. I think single layer ISR is really the fork in the road because there's still some controversy about what the best possible treatment is. I think it's hard to argue with the data on drug-eluting stents, but of course, do you want to kick down the can down the road? Because once you have a second layer DES failure, then of course the morbidity and mortality increases. So are we trying to be preventative cardiologists, Brian, by using DCBs? Let's see what he has to say.
Thanks so much. I think that's the perfect introduction. This is an area where I do think, sorry, skipping ahead here, there's a lot of variation in practice, and our own practice is evolving. And we'll get into this case, but particularly scenarios where there's a long segment of ISR and you don't want to restent a lot or a bifurcation. But for a lot of just the straightforward single layer ISR, we are treating that at this point with another drug-eluting stent. And so this is a case highlighting some of the utility that I just described for single layer ISR. So this was a 72-year-old gentleman who was down in Nantucket with an STEMI, this EKG. People were worked up down there and trying to get him up to Boston. He'd had a bifurcation PCI of his left main about 1 year prior. His EF had been 50% and it was now 30% in the context of this rhythm and STEMI. He also had some lung cancer, et cetera, sort of the usual at this point. And so here's the angiogram. He had this RCA lesion. We got some prior films that was similar to prior and certainly not explaining what was going on. And so here's the left system. You can see that there's stenting in the left main extending down the LAD. There's obviously diffuse ISR, most severe, the distal left main into the ostial LAD. And it may be hard to see. There's a little nubbin of stent into the proximal circumflex. So there was a culotte. So there's a double layer stent in the distal left main, and then single layer in the prox left main, most of the LAD, and the very proximal circumflex. And so here's a cranial view. So you can see that ISR extending down the length of the LAD. And so I think there would be a lot of ways of approaching this at every step, from how you want to start treating the vessel and imaging it, and then ultimately what the treatment destination is going to be in terms of repeat stenting versus DCB. And so this isn't really the point of all this. My general approach to these cases, I'm just going to start with roto because it's more efficient and then I don't have to go back and do it later. So I generally just buzz these and then start ballooning and imaging and get more nuanced after that. So here's 175 burr and making some space through the LAD. And then OCT'd after that. And so this started in the mid LAD. You can see there's some areas where it's not so bad. There's some neoatherosclerosis, some of it calcified. And then when we get back into the proximal LAD, there's a large tissue burden, a lot of neoathero in there. Some of it calcific there, some double layer stent as we get back into the left main. And then just kind of diffuse tissue through there, but not severely stenosed in the proximal left main. And so kind of a cut from the mid LAD there, maybe where our burr was kind of buzzing through the side a little bit, and then the prox LAD in the top right and the distal left main. And so ballooned it, and even with the rota, there's still some under expansion in the ostial LAD. So we're going to need to do some more to that. And then looking at the circumflex, making some room there. And then here, just to conserve contrast, we did some OCT on saline, really just wanted to answer the question of the distal reference size and then prove to ourselves that there was significant disease extending beyond the stent so that we were clear that we were going to need to re-stent the circumflex. And you can see here that that's the case. There's severe disease from the OM back into the proximal circumflex, some chunks of calcium there, and then just you see the stent. And at that point, with our saline injection, we kind of run out of steam and we're back in the left main. And so we, found a healthy enough segment in the OM. The prox circ is diseased, and we can sort of size all this. And so took a 4.0 score flex to the distal left main of the prox LAD, satisfied with how that was expanding, dilated the circumflex. And as I said, it was clear that the circ needed to be stented. And so I decided to just hang a little bit of stent back and crush it. There's a reasonable size mismatch there for a 2.5 reference in the OM and a large distal left main. So we put that stent there, that crushed balloons in the more distal LAD at the moment. Recrossed into the circ, did some kissing inflations. And then at this point, our hope was not to stent the single layer in the prox left main and that whole length of the LAD. And at this point, we'd ballooned it and it was expanding well. And so we took a 3.5 by 30 coronary DCB for the more distal LAD, and then took a 4.0 by 40 Ranger, which I realize is off-label, but that gave us the coverage we needed so that we weren't using a ton of DCBs to work our way back to the left main. And then we actually had taken out the Impella just to make sure everything was okay and he was doing well hemodynamically, came back and took some pictures because sometimes there will be recoil. I just wanted to make sure it was all still looking good. And so here we were satisfied with the DCB result in the left main and the LAD. And that's the story.
All right. Z, I'll let you kick off and then we can have a little bit of a discussion.
Yeah, so I think we're going to keep these sort of brief, but because we're going to plan for a discussion with everybody at the end. But a couple of, very interesting things. First, it's interesting that you're using atherectomy up front. So, Brian, is this partly a reimbursement strategy, or is it sort of a routine strategy to create debulking? And if it is, uh, how do you select your burr size if you don't image first?
Yeah, so yeah, we don't actually get paid for anything we do here in Boston. So I'm not so concerned about what the hospital gets paid for this. It's just something I've moved to over time. Honestly, it's part psychological, but w with these lesions, it is very often the case that we need multiple modalities of calcium modification, where there's virtually always at least some component where there's a calcified lesion with underexpanded stent. And it's just much more efficient to do the road up front. It debulks a little bit. And then I don't have to decide, you know what, this balloon isn't expanding. Let me go get the rota. All right, let's get a microcatheter. I just wire it with a microcatheter, switch it out for the rota wire, buzz it, microcatheter back in, and it takes 5 minutes and we've done it. And so now I know whatever remains to be done, I've done the rota. Now, then the question of sizing, et cetera. I don't know. For the balloons, it's obviously critical to get one-to-one size. I just take the biggest burr that I think I'm going to get down without getting it stuck. And so here, I think a 175, 2.0, I don't think would have been crazy. But I thought 175 was a reasonable way to make some space, debulk, and I've done it. And now I can shockwave or OPN, or here we use a Scoreflex wherever there's constraint after I've imaged and decided what a one-to-one balloon is.
Let me ask you, how do you pick your advanced lesion preparation balloon, Scoreflex, OPN, Shockwave, um, Wolverine? What's your algorithm here? Is there one, or is it
No, yeah,
whatever
I
whoever's in
think
the lab?
Yeah, I think any of these things are completely reasonable. Obviously, we don't have comparative data. Here, I wanted a 4.0, so angiosculpts out. I think a Wolverine is reasonable, a Shockwave is reasonable, an OPN is reasonable. Shockwave just takes more time. OPN, I generally put down a second wire so that when it grips on the wire, I don't worry about it. I take it out. It's just like slightly more annoying. So I thought I'm just going to take a 4.0 that I know is not going to rupture at high pressure. If it looks good, it looks good. If it doesn't, I'm going to do an OPN or a shockwave, but at least I've earned the sort of time annoyance of those things.
And I think something that you mentioned up front here was very important, and that is, uh, a second layer of stent here is a big problem. Because if you're putting a second layer of stent across the ostial LAD lesion and now double jailing the circumflex, and you've got a high risk lesion, I think the better part of valor absolutely is to try a drug coated balloon, because I think there's, like you said, there's focal ISR that's sort of easy to put a 3.5 stent into, and then there's complex ISR, which involves multiple other branches, and then the cost of kicking that can down the road is really, really is a much different beast than something that's more simple.
Yeah.
Si, any comments from you?
No, I mean, I think that there are numerous technical points that we can talk about, but certainly in the setting of bifurcations where you have overlapping stents, there is de facto two and sometimes three layers of metal, especially with a culotte technique here. And so that poses its own challenges. It's perhaps a misnomer to say it's single layer throughout. And so you had to do a lot of gymnastics just to get opened up front. I think the more sort of base case is truly a single stent with a single layer of metal. And I think we'll get to talking about how do we prepare these lesions for optimal performance, with DCB. So that hopefully we'll build on that in the next case.
Awesome. Thank you.
Thanks, Brian.
All right. Well, so next I'm going to invite Dawn Abbott. She's going to talk about a double layer ISR, and then we'll have some time to chat after.
Thanks. Let me just get this going. Slideshow. Okay, thank you. I think my case is more straightforward than yours, Brian, even though it's double layer. The patient's complex, but I think it definitely we're seeing more and more double layer ISR now, especially even in double layer DES. So I think this is a good platform to talk about it. This patient is extremely complicated. She is a woman who had extremely premature coronary artery disease back in 1998. She had a 2-vessel cabbage, and I inherited her from a cardiologist who retired, and she has had class 2 plus angina and HFpEF for probably a decade. She's had multiple prior PCIs, several of which I was involved in, but she had a DES to her ostial circumflex in 2015. That restenosed in 2016 and got a second layer of DES. She had ISR in 2020. I took care of her at that time. We elected to do laser atherectomy and a scoring balloon. This was pre-shockwave, pre-DCB. So literally she had a Elka HOBA back in 2020. At that time, she was noted to have more distal OM stenosis, and she had a single layer DES. A year later, she had severe restenosis, a second layer DES. I think the first one was a sotorolmus eluting stent. The second one was an everolimus eluting stent. She subsequently had vein graft disease and had a PCI to her vein graft in 2022. She did well for 3 years when she had subtotal occlusion of her right coronary artery, had a rotational atherectomy and DES there, continued to have angina, but calmed her down. And then by March, escalating angina. And this woman is on very aggressive anti-anginal therapy, Toprol 300, now 400, as a matter of fact, amlodipine 10, Imdor 130. She didn't tolerate Ranexa very well. She's on Effient, Repatha, etc. Everything you can think of. So we brought her back in for an angiogram. This is her baseline EKG. It wasn't much different. So I'm going to do the summary and then show you some selected images. She had a minimal left main. Her ostial LED is known to be occluded. Her lima was patent. Her vein graft and DES was patent. I'm going to show you the circumflex and the RCA, which had, moderate sort of 50 to 70% areas of stenosis. And her EDP was controlled with HFpEF medication. So here was her right coronary artery. The stent is in the distal vessel. She had a long time standing occlusion of the PDA. Her PLB is open. She had a 50% diffuse long lesion, which we'd purposely left at the time of her roto. And her circumflex has 50% proximal ISR. That was the laser PTCA from 2020. And she has the 60% ISR in her OM, which has 2 layers. We did RFR of both the circumflex and the right coronary artery, and the right was fine and the circumflex was significant. I'm just going to take a step back. This was it's actually 2021, not 2022, but this was her ISR a year after the initial OM stent. So you see the moderate disease in the proximal. This is heavily calcified. And here, a year after, she's got very severe intimal hyperplasia. I was trying to download the IVUS, but the video was way too long and I couldn't get it off the system. But this is distal reference vessel 2.3, proximal 2.6. The stent was about 2.4, and this is aggressive intimal hyperplasia in a well-expanded stent. So back then in 2022, we placed, I think it was a Promis everolimus eluting stent after predilation, and you see here's our final result. And so here's pretty standard treatment for a single layer focal ISR, second DES. We had a really nice result. So now 3 years later, you saw that she had this step up in this 2-layer stent. We actually have a wiggle wire. We're femoral access at this point because I think her radials have occluded over years, and we can't get the IVUS down. Although we did IVUS it in 2021, so we had the measurements. So we felt pretty confident about device choice here is proximal to the distal stent. You see the area, it's quite a small vessel. It's only, there's some calcium. And then just to make sure the proximal lesion wasn't what was causing a problem, again, from the pullback, we knew the distal lesion had a greater contribution to the gradient. And then we saw that here we still had a very good MLA in the proximal lesion. And again, this is heavily calcified. That proximal stent is encased in calcium. So again, we're dealing with double layer ISR. It's a small vessel. Here we're talking about a 2.3 to 2.6 vessel with already 2 layers of thin strut, but not ultra thin strut stenting. So our plan was a DCB up front. We started with just an NC balloon. And then here you see on stent boast, we want to just make sure we're getting good expansion. We took a 275 NC up to about 20 atmospheres. And then we still wanted to make sure we modified. We thought here we were under 30% angiographic stenosis, and so felt like we could do the DCB, but decided to go in with a 3.0 angiosculpt just to make sure this elbow is well expanded. And to get the angiosculpt down, we needed to anchor a guide liner or guide extension catheter close to that second stent. And I will say that there is some data on guide liner use with DCB application, because if it's going to take you too long to get the DCB to the target site, you're going to lose a lot of the efficacy. And so if I'm having a challenging case and I know I'm going to DCB, I like to use the guide liner up front to make sure I can rapidly advance the DCB when the time comes. So we use that to anchor, expand the stent, and then we used a 2.5 by 30 DCB. So we had ballooned a little bit up and down. Maybe the balloon area was about 18, 20 millimeters. We want to cover 5 millimeters on either side of the injury. And you can see here is our final result. And I just want to, just summarize by saying that it's quite a clinical challenge with double layer, because there could be difficulty with optimal stent expansion, the desire to avoid additional layers, and higher rates of recurrent restenosis. Here, because there wasn't much calcification in the lesion, we could have chosen something like laser, but high pressure balloons, either OPN, scoring balloons, etc., are also very helpful. And we can talk about some of what you're trying to achieve, but certainly we saw in the AGENT trial that a strong predictor of DCB failure was inability to achieve less than 30% diameter stenosis prior to applying the DCB. So really you don't want to apply a DCB in an inadequately treated vessel. So again, DCBs are a really good option for multi-layer DES or stent failure. In AGENT, actually, we stratified randomization according to whether it was single or double layer. So we have randomized results in the single and double layer cohort, which I'll show you briefly. And I think that's really helpful to have that data. And here's from our publication that was just published in JACC a few weeks ago in mid-August, so it's hot off the press here. But what you can see is quite clearly that patients with multi-layer ISR have much higher rates of target lesion failure and target lesion revascularization. And the relative benefit of a DCB compared to a POBA is much greater in double layer. So you see here that the risk reduction here for target lesion revascularization went from 38% to 17%, as compared to a less significant reduction in the single layer patients. So these double layers are higher risk. POBA is not effective, and these DCBs are highly effective in double layer. And not only for restenosis events, but DCB can reduce the risk of target vessel MI in multi-layer patients. So again, these are very high-risk patients where you're trying to reduce the risk of serious adverse outcomes. So again, we'll discuss it. Just remains a clinically challenging subset. in these patients, physiology may be necessary because looking at angiographic stenosis severity and ISR can be misleading, and intravascular imaging is highly important, either like a high definition IVUS or OCT. You can use multiple techniques. I know Brian used ROTO. We typically reserve that for calcific neoatherosclerosis, but I do see the efficiency in the Roto, but Elka is also a very good option here, and would consider guide extensions for rapid delivery of DCBs. And overall, again, it's just not a subset you want to be treating with balloon angioplasty. So thank you so much.
Don, thank you. And we'll get there in a second with some more questions, but I think we have a poll. Am I right, guys? We have an audience poll. So the question I'll read out loud, and then we'll sort of get everybody's input. You'll be able to vote as an audience member. Questions: what is the key challenge in treating double layer ISR compared to single layer? A is increased risk of thrombosis, higher likelihood of target lesion restenosis, greater difficulty in achieving optimal lesion prep, or reduced effectiveness of DCB. We won't hum the theme to Jeopardy, but I think we can give everybody a few minutes or a minute, let's say, to answer this question. And then we'll go over the result.
They don't let us vote.
Yeah, we're not allowed as faculty, but Dawn, why don't you walk us through as we try to pull up the results? There it is.
Okay, perfect. Yeah, we have some good distractors in there. The risk of stent thrombosis is quite low. We did not see an increased risk of stent thrombosis in agent, but again, we did see higher risk of recurrent MI. So, but not necessarily due to stent thrombosis. So nobody picked that. Certainly, most people got the correct answer, which is what we just published in the agent trial, which is that double compared to single layer, double layer have a much higher rate of target lesion restenosis and target lesion failure compared to single layer. I think question 3 is probably the most important distractor, which is greater difficulty in achieving optimal lesion preparation. That may certainly be the case in some patients, but it's not always true. I would say that depends a little bit about the mechanism of the failure and the timing of the failure in terms of neointimal hyperplasia versus neoatherosclerosis versus degree of calcium. So we don't have a clear-cut study showing that, even though inherently I think that may be true. And then drug-coated balloons are actually more effective at a 2-layer ISR than 1-layer ISR compared to POBA. So again, not compared to other modalities, but compared to POBA. So it's a pretty good question. So most of the audience got it right. So kudos to everybody.
All right. Z, any comments?
Main comment is that probably where most of the research needs to go for ISR specifically is double layer ISR. And that's why I was so pleased to see this publication in JACC, because I think I think DCBs are an incredible technology, but we need to be cautiously optimistic, right? We don't have tons of great data. There aren't huge multi-center randomized controlled trials. The largest one is, although we have some coming at TCT, I acknowledge that. But at the moment, I think it's really important for us to acknowledge what modality is most useful in what clinical situation. And so clearly this recent publication by Ajay and the group from Agent shows the benefit in double layer ISR really outweighs what happens in single layer ISR. And then of course the cost for double layer ISR of a third layer of stent, although there's very little data, seems to be appallingly bad. And so it gives us an option. And so I think this is still something that needs to be explored further, but it's an exciting finding for us that we have an option in double layer ISR with some good, reasonable efficacy.
Right. Well, I think we're staying pretty close on time, so why don't we move on to the next case? I'm going to invite Dr. Larner to present treating stent failure with DCBs, underinflation, or lack of calcium management.
Okay, you can see my slides there.
Perfect. And just go to presentation mode and we'll be perfect.
Okay, great. Okay, so this case is a 66-year-old man who has known prior coronary disease, had a circ stent placed in 1998 in the setting of angina, it sounds like at that time, and then came in many years later to another institution, so I don't have the films of it, with an inferior STEMI in the setting of stent thrombosis, and was treated, and a second layer of stent was placed in the circumflex. And so now he's been had this sort of marked increase in dyspnea over the last weeks to months, and on, following with the cardiologist, has been on robust GDMT despite this having symptoms. They got a stress echo, kind of equivocal due to his limited exercise tolerance. So then they sent him for angiogram. So these are his diagnostic films. So he has this kind of occlusion of the circumflex, the caudal view. So it seems to have some kind of distal vessel filling. We don't, I would say, typically do ad hoc CTO PCI, but given that he was, talked to the referring and they thought it probably made sense to do a try of it. It seemed like antegrade, the right, I didn't show, but was small, without a lot of collateralization to the circ. So it was, sort of thought that the antegrade approach was probably best. So it's reasonable to give it a try in this setting. And this, I should say, I joined the faculty relatively recently, just finished my fellowship a little under a year ago. So this was I was a fellow at this time as well. So one of our CTO operators who was with me for this case. So we did our kind of typical setup, 7 French, trap liner, microcatheter, workhorse just to get proximally, and then we're able to get across antegrade with wire escalation up to a Mongo, and then felt pretty good with this injection that we were where we wanted to be distally. So then we were able to daughter the microcatheter across, here we go, and then do some POBA and kind of just restore some flow. And so then we had to do a fair amount of POBA in order to kind of allow the IVUS to cross. So I will say that there's already been like some work done already, but this was the kind of first IVUS run. And I apologize if the image quality isn't very sharp, but it, there's some areas that are single layer, some that are double layer. And then it looks like there's, the second layer probably has some under expansion and may have, certainly that wasn't the primary, probably neointimal hyperplasia, but certainly probably contributed to the restenosis there. So there. So kind of similar to what the other presenters have said, I think the lesion preparation seems to be key in these cases. And so in this case, we had to do a fair amount of angioplasty to get the vessel opened up. And so primarily NC and then cutting balloon to pretty high pressure, maybe like 22, 24 ATs, which we felt more comfortable doing because we knew we were in, 1 to 2 layers of stent throughout the lesion, as compared to a native vessel. So then this was some of our repeat IVUS after angioplasty, so we could get further down into the distal vessel beyond the stent, and then here coming into the stent. So we're able to get it quite a bit more expanded. And then there's one portion in the middle where there's still some kind of right in here where there's still some residual disease there, but otherwise looks pretty well expanded compared to prior. And then still this kind of moderate disease once we come out of the stent into the circ. So given that, I think kind of like we've been saying that there's a little bit of equipoise in terms of the next step, but given that there was, some areas of single stent, but the primary area that seemed to have been occluded was mostly double stent. And so we thought it was, so we did some little additional POBA distally just to open up the OMs, and then delivered a DCB 3.0, and then for 30 seconds. And then and then this is our final result angiographically. So I think, so I think in this, and certainly with some of the more lack of calcium modification and the stent being underexpanded, then sometimes we would lean more on maybe like shock wave or something like this to see if you can potentially crack the calcium behind the stent. But I think it seems sometimes that's a little harder to do. But in this case, we thought we got a reasonable result with the Wolverine and the NCs and went with that. But I think it's interesting to see how this will evolve over time in terms of our use.
All right. And do we have any follow-up on the patient?
Yeah, so far he's doing well. Yeah, no issues so far. But we'll keep you posted. We'll see. This was a couple months ago, maybe like 9 months ago, something like that.
Awesome. All right. Well, Z, you're the imaging maven on here. I wanted to get a couple of questions in. We have some time for discussion about this case, and then I think we have a poll also. But with respect to this kind of a situation, and more generically with stent failure, in the setting of a CTO, doing IVUS probably makes sense. But in the setting of a stenotic lesion, what's your feeling about OCT versus IVUS? We've seen both examples here tonight. And is there any preference in your opinion?
Yeah, thanks, Sai. So I think it's unquestionable that OCT is a superior modality for in-stent restenosis assessment. I mean, I think we have to go away from saying that everything's the same. It's a Swiss Army knife, but you need the right blade for the right time, right? And so for in-stent restenosis, the improved resolution lets you say not only the presence or absence of neointima, but allows tissue characterization, thickness of the cap, which IVUS can sometimes struggle with, the number of layers in great detail, which of course, again, IVUS can sometimes be limited on, and then very, very importantly, the depth of the calcium. And so only OCT will allow you to measure the cap on top of the calcium. And that's very difficult with IVUS. Not to say that IVUS isn't extremely useful. That's not the point, right? IVUS is extremely useful, but for certain things, right? I think it's a superior modality for CTO. It's superior modality for multivessel. It's superior modality for left main coronary artery disease. And actually, if you're speaking strictly from the data, that's what the data shows. If you look at Renovate PCI, all of the places where Renovate PCI really won were all the places that OCT is poor, right? You got the biggest benefit. Again, left main, chronic total occlusions, bifurcation, I guess we have October, but I think it's important for us to recognize the additional value of different imaging modalities in different clinical scenarios.
So, but here with a sort of ISR CTO, you would have IVUS too, or you would have pre-did then OCT?
I would have made some space, and then I would have OCT'd.
Okay.
You know, the other thing is if you're using, and I've been through this with the sponsors actually, that if you want to see the cuts of advanced lesion preparation, like a scoring balloon or a cutting balloon, it's really, really hard to see those on IVUS. But it's actually quite easy to see them on OCT. What the relative value of those is not clear. But one thing that I think is of definite value is looking at the pattern of your dissections after you've done your lesion preparation before you use a DCB. I think that's extraordinarily important. And so I think, again, specifically speaking with regards to ISR, I think OCT gives you some added value there.
All right. I know, Brian, you chose OCT in a left vein bifurcation ISR segment, and I suspect that's because you're of the same opinion as Z.
For sure. Yeah, no, I think I agree 100% with everything on both sides there. And then also to the point of the multi-vessel, of course, like you said, I agree. If we were doing like 6 vessels here, might not have done that. But one, just being parsimonious with contrast to begin with, it certainly doesn't add much, if any. And then two, you can get a short segment with saline. I mean, there are all sorts of ways around the issue.
Yeah. Dawn, any other thoughts about that?
No, certainly we have both modalities. I mean, I think most operators, reach for IVUS, and we have the high def IVUS, and it, works well. But I agree, if you have 2 layers, if you're trying to define calcium depth, again, delivery sometimes can be an issue. Opacification of the vessel can sometimes be an issue. If you're 6 French and there's a lot of angles, a lot of calcium, a lot of equipment, sometimes it's difficult. So I think definitely if you use IVUS, it's better than angiography. So I would say if you don't feel comfortable with the OCT or it's not a good situation for it, IVUS is going to give you at least some information, but of course, it's not going to give you the calcium depth, and it's not going to give you the granularity between the stent struts and the calcium, for sure. So
And
definitely point well taken.
And I think Ziad mentioned this, but I guess just to be sort of more explicit about it and sort of how I use it, I think with OCT, for all the reasons Ziad mentioned that you can't see as well with IVUS, with OCT, I'm just more confident on my vessel sizing. If there are multiple stent layers, if there's neoathero with calcium, I am less confident on what my one-to-one balloon size is, and that's obviously critical. You're going to need to take something to high pressure, and you don't want it to be either under or oversized.
All right, that's it's worthwhile conversation, because I think that in the setting of ISR, imaging is compulsory. Obviously, the preponderance of American cath labs in particular are using IVUS, greater than OCT by far. But there clearly are opportunities to see more with the higher resolution technique. The next question, and maybe we have a poll for this case, right? Maybe we can do the poll, and then we'll get to some additional questions about this case. So for Emily's case, what is a key factor in the successful treatment of stent failure with DCBs? Increasing the dosage of the antiproliferative, ensuring proper lesion prep and adequate balloon inflation, using multiple DCPs, or avoiding the use of intravascular imaging. Emily, you want to take us through the questions here? You're on mute, just to get you back on.
Oh yeah, perfect, thanks. Yeah, so the increasing the dosage of the drug is not, it's not the answer.
Nope.
And then ensuring proper lesion preparation. I think we've all kind of touched on this in our cases. I think this is sort of felt to be a little bit the crux of the success of getting good results and success with DCBs, in terms of, trying to get the lesion, well expanded, less than 30% residual stenosis, and trying to make sure you really use whatever techniques you need to get that result first. And then using multiple DCBs in a single procedure may sometimes be warranted or needed, but is certainly not a key factor in success. And then, as we said, we want to, maybe some people just misread it. We want to make sure we do use intravascular imaging techniques. And yeah, point well taken about the OCT. We're definitely an IVUS heavy lab, but we certainly OCT is a better modality for ISR with multiple stents.
Yeah. So I think somebody's just playing with us there, but I wanted to highlight a couple of things. First, Dr. Sattler has put a question in the chat. Thank you for joining. He asks, does the calcium depth really matter? I think we use imaging, I presume, to determine under expansion. So let's see, how would you respond to that?
I would say it matters greatly, and the reason is, to be specific to Lowell, is if your calcium is superficial, if you have neoatherosclerosis that's calcium-based or neocalcinosis, then your calcium is closest to the lumen. It's very, very easy to break. Or I should say, much easier to break than calcium that's deep, that's behind a stent, or covered with a layer of tissue. So once you cover your calcium with a layer of tissue, then all of your balloon force goes into squeezing the neointima. And so being able to get to the calcium becomes much, much more challenging. In fact, we even showed that shockwave is much less effective in double layer ISR because of the layers of neointima that cover the calcification, but in single layer is highly effective. And so you think of it from a practical point of view, basically you're putting a pillow on top of a glass. And if the pillow's big and spongy and you hit it with a hammer, it won't break. And so but if your glass is on the inside of the pillow, it's much easier to break. So the depth of calcification is very, very important for your lesion preparation success.
All right, thank you. And so then let's talk about lesion preparation with respect to the different sort of types of tissue. So here we saw sort of diffuse proliferative neointimal hyperplasia. And we've talked a little bit with hand waving arguments about should we cut it, score it, ablate it in some other way. I wonder, is there a preferred technique? So, for example, in other vascular territories, the use of atheroablative techniques prior to drug delivery has been shown both preclinically and in clinical trials to be superior. We don't have those data available for human coronaries, but I wonder where is that leading edge? Dawn, do you have any thoughts or feelings about it?
No, I mean, I know with the peripheral space, like, Excite ISR, I mean, we used to laser DCB a lot of lesions in the periphery. And I do use laser a considerable amount in the coronaries for neointimal hyperplasia that is not like extremely calcified or fibrotic, as just to not have that, when you're just putting a second layer, not to have that tissue there, whether that changes clinical outcomes one way or the other. I don't know. We don't have that data. But I think, I use a 0.9 Elka if the stent's under 3 millimeters, or 1.4 if it's over 3, and try to ablate some of that tissue. I mean, be interested to see what Brian says, because I think they use a fair amount of laser also up there in Brigham. So I think certainly there is some preliminary data on DCBs using, say, cutting balloons or scoring balloons as opposed to regular balloons for a more efficient drug transfer. Again, whether that'll play out into clinical outcomes, unclear. But again, certainly when we presented at ACC, the predictors of target lesion failure in AGENT, and clearly it is applying the drug when you have more than 30% residual diameter stenosis, and also to some extent in lesion MLD, so vessel size. So I think you can't help the vessel size. You can have a small vessel or a big vessel, but you should not apply these devices to an inadequately prepared vessel. So whatever it takes, you got to go there.
Brian?
Yeah, no, I agree. Thanks, Don. Our laser use has really dropped off. I think it like we'd like for it to ablate tissue when we use it, and there's just a lot of NIH, and you image it again. I mean, it looks like identical.
Yeah.
It's not like obviously less tissue in there, and so we have used it really just as an expansion tool. And so it before we had IVL, et cetera, you laser on contrast, and you try to basically have the same effect of the little explosions. But now that we have more controlled ways of doing that with IVL, it's really just a question of expansion. And so to me, it's just what's the most efficient way of throwing things at it to get it to expand, like you said.
Yeah, and I think Sahil, you mentioned this, but we do not get reimbursed for DCBs. They cost $5,300 to $5,600. We only get reimbursed in the inpatient TPT code for Medicare. So if you have an outpatient, it makes sense to do roto or laser before you apply DCB financially. I'm not saying do it just for the money, but it does. These devices do plaque and ISR modification. So again, if we don't have the data and they're potentially beneficial in other vascular beds, then it seems a reasonable choice.
Well, that's part of the reason for asking the question, was to see what the
Yeah.
practices were out there. Emily, what is your guys' approach? I know you showed us an example, but on balance, what's your lesion prep that's used the most frequently?
Yeah, I'd say we don't do a huge amount of laser. I'd say the like calcium modification, I think probably most people in our lab, if the balloon is deliverable, might start with shockwave, but otherwise, if you're having trouble delivering, then like escalate pretty quickly to rota. And then yeah, but I think the laser we do sometimes use, like we said, if we really are thinking the new intimal hyperplasia is an issue, but I would say it's like a handful of cases a year probably that we do the laser.
All right. And there's a lot of comments in the chat about the bottom line is make sure it's big enough and then apply the drug. So Z, I wanted to come back to you about a couple of scientific points as the erstwhile molecular biologist of the group. A lot of discussion about whether or not the drug should be the last thing that touches the artery. I'm a guy with a background in drug delivery too. I have my opinions, but what do you say and what do you do in your practice?
I don't believe that there's any data to support the fact that the last thing that has to happen is the drug touching the wall. I mean, if you just a little bit of common sense would tell you if you're in arterial pressure, that's like spraying you with a power washer. So if the drug's going to come off, it's not because of your IVUS catheter. I can pretty much go on record with that.
Yeah, I think you're right. I just like to dispel that myth insofar as I can every time I have the opportunity. So the binding happens on the order of milliseconds. Yes, there's particulate on the inner lining of the vessel wall, but the KD is so avid that the drugs bind very avidly, especially with paclitaxel. You don't really have to worry about it. The final thing I would wanted to ask, and we'll get some additional round robin comments, is what is the adequate lesion length that one would consider appropriate for treatment with DCBs, or is there no limit?
I think the limit is financial, right? So let me tell you, on last week on Thursday, I had a guy with basically diffuse ISR all through the RCA, right? He'd failed brachytherapy. We pulled out all the stops. I ended up using 3 DCBs, right? That's almost $17,000. So I'm in the process, and thanks to Boston Scientific, that we are doing this collaboratively to see whether the TPT is going to pay for all 3 of those devices. Technically, it should, but there are some nuances to ensure that you're going to get payment. And I think if you have ISR, certainly double layer ISR, and you can get the devices covered, it is a treatment of choice. But we have to add cost into this equation because the APC for that PCI was $5,500. So it's unaffordable to do this on these types of scales unless we find out that we're actually getting paid using TPT.
Other thoughts, any of our panelists?
No, I think the diffuse lesions are exactly where the benefit will be. And then, if it focally restenosis, you can use some other therapy. No, exactly. Like recently I had roto, full stem to stern, CTO, roto stem to stern, balloon, spot stent, critical areas, and DCB the mid to distal third of the vessel with 2 long DCBs. It's I think thankfully DCB stance, which is the next agent trial, is going to have a lot more complex lesions with a lot of bifurcations and very long lesions. So hopefully people are going to be enrolling in that trial or at least awaiting the results. And then, we'll soon have small vessel indications, and then we'll have long lesion indications, and we'll have bifurcation indications, and the data can keep coming.
I think you mentioned something really interesting, and that is for those of you who have seen a DCB failure, the DCB failure looks totally different to the original failure. And so often you end up in this situation of this long 30 or 40 millimeter diffuse ISR that you've DCB'd, and then it comes back, and if it does, it comes back with like this 4 millimeter ISR that you put this 8 millimeter stent on, and you've kind of really prevented yourself from putting this very, very long stent. So this is, I think, something that should be interesting. Obviously, I think in AGENT we didn't have all the films for the patients who had target vessel failures, but it is a very important concept to see, does the biology change to the point at which you're getting an entirely different complexity of PCI when they're coming back after DCBs.
Yeah, I mean, I think we're a little limited in the ISR population because we're talking about stented vessels, but when we get to the de novo population, and then you've got 40% of people who will positively remodel, then it's a whole different ball game, right? And so you can really wait and limit it. I mean, I'm telling people now, I think Lowell said, like, people who fail brachy are probably going to fail DCB. I've had a couple of those where we send them up to Brian, they get the whole vessel DCB, that brachy, and then they have focal recurrent ISR. And we just sort of bring them back every 6 months and keep DCBing them, and what's the alternative? They're generally not vessels that are bypassable, not going to brachytherapy them again, not going to stent them again. And so it's like a spa treatment. You come back, you get a DCB, get some more drug, and then you don't have angina. I mean, this is really angina relief. These patients have really refractory angina. And so I think if that's what we have to do, we're not going to have a permanent solution. So.
Brian, go for
Sorry, I
it.
was going to say, I think, Don, you brought up the good point of bifurcations. I think there are situations that are just tough to get around using multiple DCBs or coronary DCBs. We're pretty liberal with the peripheral, which are much cheaper. If it's a big RCA or left main LAD, you get a 60 millimeter peripheral balloon down there. That covers a good chunk of it, and you use one coronary balloon or something. I realize that's maybe not something we're supposed to talk about, but.
Well, it's real, it's real world, and it's what's happening out there. We see that.
But there's challenges with that too, Brian, right? We published we published the data for that in SCAI, and our event rate with peripheral DCB in the coronary was awful. Yep. We had like a 43% target vessel failure rate within 2 years. And then, of course, you have to get that truck in there, using V18s in the coronary and stuff like that. So there's some challenges with using that too.
Yeah,
for sure.
I'll also remind people it takes a while to deflate, so you don't necessarily want it in the left main. Like a vein graft, maybe a RCA, maybe, but
for a long time, my job at Columbia was to keep in stock the longest and shortest DCBs available on the market for different purposes. But fortunately, we don't have to do that anymore, and hopefully, our results will be more like that which we saw in the Asian trial than in some of our other ad hoc experiments. Well, so we're running close to the hour. I wanted to just give Z your chance to give us the final parting shots before we bid everybody adieu.
I mean, I think to put this together, I think we're all optimistic. This is a new technology for us. We're excited to use it. We're 10 years behind Europe, but we're seeing that it certainly works in in-stent restenosis. We're building an evidence base, and I'm really excited about what's going to happen at TCT. I'll be in the room to see both of the solution studies, to see whether or not we're going to have some competition, which I think will be good for cost, and B, whether we're going to go into these all-comers for de novo disease and what that actually looks like. So I'm excited to see where this field leads, and I'm going to sort of finish how I started and say I'm cautiously optimistic.
Indeed. Well, we want to thank everybody again for joining us for this webinar series from SCAI. I want to thank our panelists who provided great cases and all of you for your great participation. This is an exciting time in the space, and we look forward to not only the further data evolution from the agent program, but also from these forthcoming fast followers. So again, on behalf of SCAI, I want to thank you for joining us. Please look for the emails and otherwise log into your SCAI accounts to get your CME credits. We'll see you again soon. Good night, everybody.